Good evening, Isra. We miss you too here. Good evening, Isra. Nice to see you back. Isra is one of a good student who got very nice marks. Isra is one of a good student who got very nice. Okay, so should we start with queries? Okay, starting with this question. Good evening, everyone. Due to some problem, we are not able to connect with the camera. Okay, so let's see if it works in near future. Okay, so is the screen visible? Audio video is clear. Please help me. Audio video is clear. Okay. So first question, this is a question from NEET PG 2023. It has also come in 2020 and it will come again and again in future also. This is for also come in FMG 2020, right? FMG 2020. What it is saying, what is this? That there is married life of 2 years. It is an infertility patient and she was put on HMG. So HMG is the one hormone which is responsible for hyperstimulation, one which we know as PCOS. Okay, so and HMG is responsible for two effects. In any way it can be asked, HMG is responsible for two effects. Number one is yeah, HMG is responsible for two effects. Number one is it causes hyperstimulation. It causes hyperstimulation. And the next effect is that it causes multiple pregnancy, maximum hyperstimulation. Good evening, Nimra. Maximum hyperstimulation, bacha, and it causes maximum multiple pregnancy. Okay, so if there is any risks as such of hyperstimulation or of you can say multiple pregnancies are too much, then the answer is HMG. That is what they want to tell you by saying that HMG is given. It causes these two effects very largely. And then they are saying that she developed dyspnea and abdominal pain. Dyspnea and abdominal pain on the patient of one who is on the infertility treatment and given HMG, of course, and the ultrasound report is showing such a big ovaries. So it is a hyperstimulation syndrome. What happens in hyperstimulation syndrome? Just in a brief, vascular endothelium growth factor is released, which causes the intravascular fluid to go into the extravascular space. Because the intravascular fluid is going into the extravascular space, so there is hypercoagulability in the vessels and there is correction of the fluid in the extravascular space, causing pulmonary edema, causing ascites and all these things. So answer is OHHS. Okay, from regarding this thing, you should read OHSS in detail and about HMG in detail. Next is, this is a question which is asked in NEET PG 21 and the answer here is question here is that this patient was having intramural fibroid. Patient was having intramural fibroid 7.5 and 5 into 5, one at the right cornea and one at the left cornea. Now these two fibroids, they are blocking the ostia. Okay, rest all the parameters are normal. That is what they are saying here. Rest all the parameters are normal. Again they are saying. So what we should do? So as you all know, whenever there is corneal block, so ovum will not come, right? So we will go for laparoscopic myomectomy, because this is something by which we can avoid the hyperstimulation. We can avoid the IVF. So more we are close to conservative procedure, more we are successful. Okay, so IVF is not one resort we should give the patient, and no artificial reproduction. By doing the laparoscopic myomectomy, we can save the IVF procedure. Okay, in OBS we should save the cesarean procedure. In the gynae we should save the surgeries. Okay, the most likely site of block in hysterosalpingography. Now you can see here that these tubes, they are dilated up till end. See, these are dilated up till end. So in these photographs, either it will be a tubal block bacha or it will be a corneal block. So if the tubes are dilated till end, it means it is a femoral block. And if the tubes have been blocked at the starting, somewhat here, then it would have been the corneal block. But since the whole the tubes is delineated, so it is a femoral block. Good. This is a question which is asked in NEET PG 2017, that the patient has come with bilateral corneal block. Now bilateral corneal block is there on HSG. Okay, this bilateral corneal block is there in HSG. A great disadvantage of HSG is that it leads to physiological. In HSG, the patient suffers lot of pain. So there is physiological, out of pain, there is bilateral corneal block, which is not seen in the best test, which is the laparoscopic chemopertubation, which will be also known as hysteroscopic cannulation. Okay, so we should not go for IVF. Here again we are following that thing. We should avoid IVF. So if on hysterosalpingography the report has come of bilateral corneal block, it is not a confirmed block. It can be due to the physiological bilateral corneal blockage. So here the answer is we should go for the further best test is for the tubal patency, that is bilateral chemopertubation or hysteroscopic cannulation. Okay, now this is the INS 2018 question. It is saying that there is secondary amenorrhea and after a abortion, or you can say after a DNC, and FSH is 6. Since FSH is normal, since FSH is normal, it means that hypothalamus is functioning very normal. Okay, since FSH is normal, it is functioning very normal, and there was a pregnancy also, after which there is secondary amenorrhea. It means in the past everything was going normal. Pregnancy is also there. It means estrogen, progesterone, all the hormonal status, they were quite normal, right? They were quite normal. So you should know that here that everything was normal. Something has happened after the DNC, and after that also the patient is having, after the DNC also the patient is having the FSH normal. It means something is at the level of endometrium or the uterus. So answer is uterine synecdoche, which is also known as Asherman syndrome. In Cartagena syndrome cause of infertility. So answer here is asthenozoospermia. So what happened in asthenozoospermia is that what happens in asthenozoospermia is, astheno means weak sperm. Sperm's count is okay, but there is defect in the sperm, that is asthenozoospermia. In the Cartagena syndrome, there is primary ciliary dyskinesia. Yeah, dyskinesia. There is dyskinesia. Cilias, they are not motile. They are primary ciliary dyskinesia, and it leads to non-motile cilias in the fallopian tube and non-motile sperms. Okay, so that is stenospermia. 25 years old woman underwent induced clomiphene in induction, and there was 8 follicles, and the estradiol level was hypostimulation. Okay, usually when we are undergoing any ovulation for the IVF or anything, we want 15 ovums, around 15 ovums we want. So since it is 8 ovums, 8 follicles, so it is a hypostimulation. Okay, so serum estradiol was 808. So per follicle rise in estrogen is 200. Since there were less follicles were made and the rise in estrogen is not appropriate, so since it is 8 follicles, so 8 into 200, it should be 1600. 8 into 200 should be 1600. It is half. It means that follicles, they are not producing the good estrogen. Okay, the estrogen is also produced less, so that is why answer is withhold HSG. So that by that is they are taking more time to mature. They are not producing 200. They are taking more time to mature. Any problem, Nimra? Nathi Harike, any problem? Morning you were asking me about this. Any problem? I hope you will write in the continuous GnRH. Continuous GnRH, it is equals to, yeah, thank you Isra. Continuous GnRH is equals to, yes, can you help me? It is antagonist or it is progonist? It is antagonist. Since it is continuous, it is antagonist. Okay, for GnRH to function as GnRH, they should be pulsatile like it is in our body. So they are antagonists. So we want that it should be given in the conditions in which there is increased is GnRH. So the conditions are prostate cancers, male infertility, and the so the answer is male infertility. In male infertility, there is already decrease in GnRH. Okay, male infertility, there is decrease in GnRH. So we will be giving in precocious puberty, we will be giving, no doubt we will be giving antagonist GnRH, because the puberty is coming fast. GnRH is released by the body in the early stage. Okay, in prostate cancer, you all know GnRH is increased. In endometriosis, we want the menstrual cycle to stop. When the menstrual cycle will be stopped, when GnRH will not be released. Okay, whereas in the male infertility, we want more GnRH to release. Okay, got it? Now all are true regarding Escherman except. So answer is causes primary amenorrhea. So this is the answer, because as we studied recently only, it causes secondary amenorrhea, because it usually develops after DNC and tubercular pathology. First everything was occurring normally, then the endometrium had the adhesions, the uterine cavity had the adhesions, and then this happened. Okay, next is a couple visits the clinic with primary infertility for 2 years. Semen analysis show the azoospermia. On examination, the male partner has gynecomastia, sparse hair, and small penis. So what is this? This is the case of primary infertility and azoospermia. It means that GnRH is not released. Okay, it means that GnRH is not released. Or yeah, answer is Klinefelter syndrome. It means here they are saying that it is a small penis, sparse hairs and azoospermia. Either the GnRH is not released or testes are at defect. Testes are affected, because they are clearly saying that it is a small penis, sparse hair and azoospermia. It means testosterone is absent. Okay, so this clearly means that testosterone is absent. So when testosterone is absent, it means it is a testicular failure. Testes are not working properly. So out of all these, only in the Klinefelter, the testes are not working properly. And these all are the clinical features. Okay, and mind you, here GnRH is increased, because there is no testosterone production. Due to the no testosterone production, there is the loss of the negative feedback. Okay, good. Now here, this is a HSG of Asherman syndrome that we already discussed. In Asherman syndrome, it is due to two etiology. Number one is DNC, high intense DNC, and number two is tubercular pathology, right? Tubercular pathology, right? We studied that, right? And in the what is the name of this HSG? It is moth-eaten HSG. There will be filling at some space and there will be non-filling at some space. Okay, so this is uterine synecdoche. Okay, so here also they are telling you there is history of DNC, and then on HSG there is sometimes it is filling and sometimes some spaces it is not filling. So the answer here is Asherman syndrome. Good. Okay, now this is the instrument by which we do the HSG. How we do the HSG? In HSG we put this instrument here in the cervix cannula, and that is why it is screwed like this. Okay, and from here distal end we put the dye, HSG oil soluble dyes, and then we take the X-ray whether the dye has come out of the, it is a radiopaque dye, whether the dye has come out of the fallopian tubes or not. Okay, and if the dye has peritoneal spill, then it means that it is a case of patent tubes. And if it doesn't know, and the name of this cannula which I asked in the evening quizzes, Leach-Wilkinson cannula. Okay, so this is again a question asked in PGI. So I think again it has been answered. The answer here is cause primary amenorrhea. Asherman syndrome always causes the secondary amenorrhea, and this part is right. It can be caused by TB. In Asherman syndrome there is intrauterine adhesions. It can be caused by DNC. Extensive curettage leads to it. Can be viewed by hysteroscope. Yes, these adhesions can be viewed by hysteroscope. All of the above is not correct. Okay, so it leads to secondary amenorrhea. Nulliparous lady married for 5 years came for the infertility treatment. She is ovulating regularly and normally, which suggests that ovulation has taken place. So answer here is high progesterone. Why not high FSH? FSH is high in, very good Isra. FSH is high bacha in the conditions where the testes or ovaries are not functioning. Ovaries not function, then it leads to the increase in the FSH. Okay, due to the loss of negative feedback, because if ovaries will not be functioning, then there will not production of the estrogen. If estrogen is not produced, then no one will give the negative feedback to the FSH. So you can't. So if estrogen is not there, how you can say that ovaries are not functioning, right? So how you can say that ovulating regularly? Okay, it's wrong. Low basal body temperature on ovulation. The as progesterone is a thermogenic hormone. The temperature increases near ovulation. High LH of course occurs, but it is not diagnostic, as you know, because the surge occurs only for a fixed time, right? On the 14th day, the LH surge occurs on the 14th day, so it has become very unlikely to diagnose the LH. High progesterone is of course, because if the ovulation has occurred, then there will be formation of corpus luteum, and then there will be formation of progesterone by the corpus luteum. So this is right. Marker of ovarian reserve estimated. So that is what I told you in the morning also. I gave a message to all. Anti-Mullerian hormone is a best marker for the ovarian reserve, that whether the ovas are becoming of good quality or not. Which of the following is the first line of drug for follicle induction in infertility? So the answer is letrozole. Okay, there are two ovulation induction drugs, clomiphene and letrozole. I have already explained to all of you that clomiphene has been replaced by letrozole, and letrozole is the drug of choice. Okay, in couple initial workup done for infertility, of course it will be semen analysis, because semen analysis is something a very easy test. It can be done on it is a very low cost. It costs a very low cost, and it is a non-invasive procedure, isn't it? So semen analysis, it is either A or B. Okay, now chest x-ray and Montooks are done in the TB patient. Not every infertility patient is having TB. So the other tests are semen analysis, tubal patency test, and ovulation test. Most common cause of infertility reason for the infertility is the ovulation problem, and ovulation is the most common cause. Now you can see here that you are not able to see any of the fallopian tube, right? So this is bilateral cornual block. Okay, so these all are previous year questions. Okay, a 35 years female presents with infertility. She has previous history of PID. Since it is a previous history of PID, and we have learned in the genital infection chapter that when there is a previous history of the PID, bacha, then what are the affected part? The part which is affected is fallopian tubes. So there will be tubal blockage, and to check the tubal blockage, what is the test? The test is the HSG. Okay, here it is that this patient is having wing adnexal tenderness, cervical motion tenderness, and cervical long-term sequelae of these conditions. So now this patient is having adnexal tenderness, cervical motion tenderness, long-term sequelae. This cervical tenderness and adnexal tenderness along with dyspareunia, this indicates PID. Okay, PID, right? So the long-term sequelae of Dr. Isra, in endometriosis, adnexal tenderness is rare. Okay, so that's it. And so the long-term sequelae of it is infertility. This long-term sequelae of PID have been asked many times. So one is infertility, and the second is pyometra. Okay. Precocious continuous GnRH are the GnRH antagonists. They are used in all except male infertility. Again, the answer is male infertility. I think this question has been repeated. What is true about AMH? I always tell that they ask you the biochemical nature of the AMH and HCG. Both are glycoprotein. Okay, so this is correct. First sentence is correct. It decreases the sensitivity of preantral follicle to FSH. It is correct. What is their function? They are released after the puberty, and slowly they decrease the sensitivity of the preantral follicles of the FSH. And it is not a lipoprotein, it is a glycoprotein. It correlates with the pregnancy outcome. No, it does not correlate with the pregnancy outcome. There are many other factors for the pregnancy outcome. It is one of the factor. If the AMH is okay, then the ovum is okay. Okay, AMH is something related with ovum 101%. IVF pregnancy success depends on implantation, ovum extraction, on the multiple ovum induction, all these things, not only on the one ovum quality. It is the best test in passing on day 2. It can be done on any day. It can be done on bacha any day. What is the half-life of letrozole? It is 45 hours. It is asked here in the INS set. It was asked. Why it is asked here? Because as the clomiphene, it is not teratogenic, whereas letrozole is teratogenic. So they ask you that why then we are using the letrozole, even it is teratogenic, because it has such a short half-life, 45 hours, that before the ovum is formed, it acts. Which of the following is associated with Kallmann syndrome? In Kallmann syndrome, there is decreased GnRH. There is decreased GnRH, and due to the decreased GnRH, there is primary amenorrhea and no secondary sexual characteristic, and that is why the patient suffers from infertility. Very characteristically, these patients, they have anosmia. There is no chance of precocious puberty since there is no GnRH. Okay, so this is wrong. Whitefield-like and syndactyly is not there. Identify the instrument used to inflate the peritoneal cavity. The instrument which is used to inflate the peritoneal cavity is Verey's needle. I know you have seen it in the morning. Note true about the clomiphene syndratus. It causes monofollicular development. No, it causes multiple pregnancy. It causes multiple pregnancy. Okay, that's all for today. Any queries, please you can ask me in the today's quiz. If there is any queries, you can ask me. In this today's quiz, you have query in 13. Yeah, I'm seeing that. Just a minute. Infertility with bilateral tubal blockage at conua, best method is. Since I already told you that on HSG, the bilateral tubal blockage is not confirmed. Okay, bilateral tubal blockage is not confirmed because we often see bilateral tubal blockage due to the pain. So if there is conval blockage, and that also bilateral, it 101%, it means that it is due to pain. So we have to clear it by the laparoscopic chemopertubation, or you can say hysteroscopic cannulation, or laparoscopy and hysteroscopy. Anything else? Any other test you want to know? Any other question you want to know? 22. Okay. The risks are increased in IVF pregnancy except. So whenever we are doing IVF pregnancy, to increase the chances of success, what we do is we transplant 2 or 3 embryos. Okay, so we transplant 2 or 3 embryos. So intentionally we do multiple pregnancies so that at least one pregnancy gets successful. Okay, And yeah, the ectopic chances increase, or you can say heterotopic chances increase. This is why this is so because why it is so this is so because the most commonly the cause of IVF is tubal blockage. Okay, so when there is tubal blockage, you can understand that there can be chance of ectopic and heterotopic pregnancy. Okay, so do you understand, Isra? Anything else in today's quiz? Yes, please. Anything, any question in today's quiz? In evening quiz? Question number 3. Clomiphene citrate is not the one which causes hyperstimulation, but I told you HMG is the one which causes hyperstimulation. Rarely we see hyperstimulation with clomiphene. Okay, rarely we see hyperstimulation with clomiphene. Rest all the statements are correct. I hope you are able to go for it. It is used for ovulation induction. Yes, it is used for ovulation induction. Multiple pregnancy chances is 3 to 8%. Yes, it is 3 to 8%. And letrozole has more live birth rate than clomiphene. It is correct. Okay. Anything else? Please feel free to ask if any problem. Can we close the session? Thank you, Isra, for joining. Thank you, each and everyone, for joining us. See you soon in tomorrow's quiz, which is on male infertility. Thank you.